To understand small intestinal bacterial overgrowth, SIBO, it helps to understand a bit about our anatomy. Normally, the vast majority of our gut bacteria live in the large intestine or the colon. They belong there and do wonderful things for our overall health. The small intestine, however, is where we absorb our food and is supposed to have relatively few bacteria. SIBO happens when bacteria from the large intestine migrate upwards and overpopulate the small intestine. You can think of it like weeds growing in the wrong part of the garden. When you eat, these displaced bacteria ferment your food before your body has a chance to absorb it. Unlike inflammatory bowel disease, which is driven by immune system inflammation, SIBO is primarily a problem of bacterial location and volume. However, it frequently overlaps with irritable bowel syndrome or IBS. In fact, a significant proportion of patients diagnosed with IBS actually have underlying SIBO as the root cause of their symptoms. When these bacteria inappropriately ferment food in the small intestine, they produce a lot of gas. This leads to the typical symptoms: severe bloating, especially within an hour or two after eating, excessive gas and belching, abdominal pain, and changes in bowel habits, often diarrhea, but sometimes constipation. In severe cases, it can even cause fatigue and vitamin deficiency. Small intestinal bacterial overgrowth, SIBO, is a master mimic. Its symptoms are virtually identical to IBS, lactose intolerance, celiac disease, and general food intolerances. Patients often spend years trying various diets without success because the underlying bacterial overgrowth hasn't been identified. Furthermore, it usually develops because of an underlying issue, like sluggish gut motility or previous abdominal surgery, making the clinical picture quite complex. Because symptoms alone aren't enough to confirm it, we rely on specific tests. The most accessible and common test we use is a hydrogen and methane breath test. It is non-invasive and can often be done at home or in the clinic. Here is how it works. You drink a specific sugar solution. Human cells don't break this down quickly, but the bacteria do. As the bacteria in your small intestine ferment the sugar, they release hydrogen and methane gases. These gases are absorbed into your bloodstream, travel to your lungs, and are exhaled. By asking you to blow into small tubes every 15 to 20 minutes over a few hours, we can measure these gases. A spike in gas levels early in the test strongly suggests that the bacteria are hiding out in the small intestine. While taking a fluid sample directly from the small intestine during an endoscopy is considered the gold standard, it is expensive and invasive, so we usually rely on the highly effective breath test for everyday diagnosis. Treating SIBO is a highly individualized process. We aren't just trying to clear the bacteria, we are trying to stop them from coming back. The frontline treatment is usually a targeted course of antibiotics, most commonly rifaximin. Unlike standard antibiotics that affect your whole body, rifaximin stays almost entirely within the gut, working locally to clear the overgrowth while being gentle on the bowel. We also use dietary changes as a supportive tool. I often recommend a temporary low FODMAP diet to remove highly fermentable carbohydrates. which effectively starves the bacteria and reduces the symptoms while the medication works. And in terms of how I decide what is right for you, it depends heavily on your breath test results and symptoms. If your test shows high hydrogen and you have diarrhea, rifaximin alone is often the choice. If your test shows high methane and you suffer from constipation, we usually need to combine rifaximin with a second antibiotic, such as neomycin, to clear those specific methane-producing organisms. Finally, if your gut is moving too slowly, we might prescribe a prokinetic medication to keep the food sweeping through the digestive tract properly so that the SIBO doesn't relapse.